Hello everyone, welcome to another episode of BAEP Talks with. I am Jasmine Evelyn. I am your host for today. Very happy about that because Julia has switched roles. She's now on the other side of the interview and she'll be sharing today with us a bit about public health. Something that you're wearing actually. Tell us a little bit about it.
Thanks for highlighting that. I think, given the current global circumstances that we're in, I thought, the message, and you're going to hear my dogs in the background, apologies. I think, the messaging, the messaging in the shirt is basically clear and, really straightforward. Science is real. Black Lives Matter, no humans are illegal, love is love. Women's rights are human rights, and kindness is everything.
So, I love it. Especially the first line right now. The first two lines are very important right now. But yeah, science is real. Black Lives Matter for sure. Mm-hmm. So let's hop into it. Let me introduce you to everybody. So Julia is a public health analyst currently based in the U.S. And she's from Barbados. We all know that, but just making it clear for anybody watching it from overseas. She graduated from the University of the West Indies, Cape Hill campus in 2010, where she obtained her B.Sc in biology with microbiology and with honors. She was a science and health educator for the next 8 years in Barbados, teaching C-set chemistry, biology, physics, and integrated science. So during that time, while doing all of that, she gained her master's in public health with a specialization in global health from the University of Manchester in the United Kingdom in 2017, so busy bee. Julia always held a special interest in the intersection of health and human rights and co-founded the Barbados Association of Endometriosis and P.C.O.S. BAEP with Don Williams and the Board of Trustees in 2016. She sought to do this after her personal struggle with endometriosis and subsequent diagnosis when it was recognized that community-wide education on these women's health conditions was still needed. We know a little bit about your background from, the bio, but still tell us a little bit more about you and who you are and then why you decided to study public health. So I'm very interested in this talk because public health, I hear about it, but I don't really know exactly what it is. So school me.
Oh, thank you. So I guess from as long as I can remember, I was always fascinated with healthcare and communicable diseases, infectious diseases, and their control. And my father worked in my formative years in the Ministry of Health. And so I would sometimes visit him at work and observe the different players throughout the system. My dad worked, I think, in human resource administration. And so I'd see him outside of the basic oversight rank, role of the ministry and have a lot of direct engagement with the medical and healthcare personnel, like the sisters and the other nurses, doctors, orderlies, attendants, techs, diagnostic staff, throughout the different entry points in the system, like the polyclinics and, of course, the Queen Elizabeth Hospital and some other hospitals that we also have back home. And so this really piqued my interest in this sector. I even remembered when I was at B.C.C, Community College, we had a project on pathogens and communicable diseases, and my group focused on the Black Plague. And from then I was hooked on learning more about communicable diseases and control and the different agents and the different, technologies and methods used to control these agents. And so I realized during my B.Sc, I was more concerned with studying disease trends and population health as a whole and community health and the determinants of health, including things like access to healthcare. And then I realized that fell more under public health than it did squarely medicine. And so when I recognized that, I did some research and I applied to the University of Manchester in 2014. And then ironically, that was the same year I got my diagnosis of endometriosis. And then I enrolled into their Master of Public Health program. And the rest, as they say, is history. We are here now.
Yeah, that's great. And it's still good that because I can imagine having that diagnosis, which is a huge, what do we call it? On my farm, I usually get put if they had any like changing events. That was like a huge thing to have on TV. And then starting this new program was a huge thing that happened as well. So it's really good that you still, push through and persevere. It speaks a lot to your, strength as a person.
I appreciate that. Thank you.
Tell us now the difference between public health and medicine. This is important.
This is important. And so I think I would like to paint a picture of, the patient. So with public health, the patient is the population. So that the population is the unit, but then they're individuals in the population, right? And then with medicine, clinical medicine, the patient is an individual within that population. So there's an overlap between public health and medicine, but public health is, concerned with the state of health and well-being of the population. And then the main goals of public health include developing strategies and implementing policies that maintain the health of this population. And, it aims to provide maximum benefit for the largest number of people. And an example that I can bring to the fore right now is how we had to, go into quarantine for, coronavirus, how a lot of us are still in quarantine for coronavirus, the social distancing measures, and then all of the other practices that we are utilizing right now, hand washing, even though that should have been something that was concrete, but all of these different things that we are really working hard to make a habit in the whole context of coronavirus. Those are public health strategies. And other strategies, again, also the coronavirus, would be like the vaccine rollout, and then like general immunization, sanitation, and hygiene practices, and then community-wide educational campaigns like anti-smoking campaigns, drunk driving or the prevention of drunk driving campaigns, wearing seatbelts. A lot of people don't think of it, but that's a public health measure. And then things like healthy eating and so on. Both approaches, public health and medicine, are systematic, and public health really does try to be as evidence-based as possible. So, it's not just anecdotal, even though anecdotal evidence informs research, but we really try to have best practices apply to situations and really model them for the context. Both medicine, clinical medicine, and public health do focus on disease prevention and intervention, but from different perspectives, but both still inform each other.
I think public health, I think, okay, they're the people in the background gathering the research. Obviously, this is just my primitive understanding, and then they are breaking it down in a way that we, the public, can understand, and then go and execute.
It's not primitive. So that's basically what it is. So we public health professionals engage at the community level. We speak to persons within the community and get feedback from them to then inform our policies, inform the interventions that we then develop out to then go back and kind of apply to the same community. So you can't, it's not best practice if you're applying an intervention to a community without knowing the community needs and the community's context. And so that's why with the bulletins that are coming out, a lot of the times, something as simple as, translating it into not just being digestible by the everyday individual, but just language and culture. So taking all of these things, and we will talk about this more, I guess, with social, I can mention the social determinants of health. All of those things play a part in, the campaigns that you roll out, and how they can be applied. So that is part and parcel. Communication and collaboration are part and parcel of, a good public health strategy.
Okay, yeah, I did not think of that. I guess you also have to think about, is it a part of it also where you're thinking, okay, we know that lay persons will not do X, Y, Z if we put it like this. We have to put it in a way. Is that part of it as well?
I mean, it is, but there's only so much you can do to a point, because again, you have to remember it's about the maximum benefit for the most people. And so, again, for instance, we're in the midst of it, so let's use it, coronavirus. So now everyone has agreed that you're supposed to wear masks when you go outside.
Right.
It's every agency, every major public health agency has said, wear a mask. Everyone still isn't wearing a mask. So there's only so much you can do. I'm seeing that, you know, in Barbados, the majority of people are following those guidelines and are wearing their mask and are doing their socially distancing and whatnot, which I applaud the community for. But yeah, there's literally so much you can do, because everyone should have, you know, their own autonomy, and, you know, they decide what they want to do. But then you also have to consider where your human rights impact my human rights. And I think that's a point of contention that we're having right now with the whole coronavirus thing, and people being, you know, not happy with a lot of the strategies that have been implemented, and not wanting to wear a mask, even though, like, doctors, when they're in surgeries, wear masks for hours on end, and, you know, they have to. But yeah, so you can only do as much as you can with the information, and then it's up to the individual to make that decision. Yeah.
Mm-hmm. Right. So then let us know a bit about the basic principles or tenets of public health.
So public health, tenets of public health. In public health, activities include, so the pillars would be like monitoring the health status of a community and identifying issues within a community that need the public health approach, and investigating these problems and hazards within a community, informing, educating, and empowering people about health issues, which is, I would like to say, something that BAEP does and does well. Developing policies and plans to support community health efforts, enforcing, and I want to put here, enforcing good laws and good regulations that protect health and ensure safety, and then, you know, just linking people to the resources. And so that's like part and parcel. There are a lot more, but I think that that's part and parcel of some of the tenets of public health.
Right.
A lot of research, research is really important. I forgot to mention that.
So public health. So speaking about health, everybody knows about health and being healthy and health and safety, etc. But we don't realize how much social determinants, or how our social life, or our, you know, where we are, our physical environment can impact our health. So, you know, tell us a little bit about social and physical determinants of health and why this is so important in your work, and it's so important for everybody.
Right. So I think it's important to define what a determinant is. Just broadly put, these are factors that impact your health, whether or not you recognize they do. There's some form or fashion in which they impact your health. And so you have the overarching determinants of health, which can then be subdivided into physical determinants of health and social determinants of health. And these are the non-medical factors that can impact your health and well-being as an individual, and then the health and well-being of the wider population. And so things like where a person is born, the social conditions that they're born into and they live in and they work in can affect their risk factors for developing and or contracting a disease or condition. And then that can also impact their quality of life as well as their life expectancy. And it's important for us to realize that, you know, yes, there are genetic factors which influence our health, but health starts and can be improved or worsened by the conditions in which we are situated in. So in our homes, our schools, our workplaces, our communities, those really influence our health and well-being. So physical determinants of health include your built environment. So the buildings, roads, and sidewalks. And growing up, I took sidewalks for granted. I just thought, you know, they were there or they weren't. I would still be able, because I'm able-bodied, I would still be able to get where I was going whilst I was walking. And it wasn't until I, you know, started to study public health and I was like, sidewalks, and then, just general safety, because it's safer to have a path allocated to pedestrians on a road, but then accessibility, and it speaks to the whole concept of inclusivity and, ableism. And so having a sidewalk and having things like ramps, those are physical determinants of health, because lack of these things can basically be barriers, not just physical barriers, but other barriers to the access, the access to resources for a person. And then housing and community designs, whether or not, you live next to an industrial area, so the exposure to toxic substances. Then, your aesthetic element, your natural environment, like green spaces, and, in some places now they're deliberately including the presence of green spaces within, their plans for development. Transitioning into the social determinants of health now. This is basically the availability of resources, access to things like education, jobs, economic opportunities, access to healthcare, the quality of education you have, the quality of the job training that you've received, the social support, your family, your friends, your community, public safety, also the types of exposures you've had and the culture you've grown up in. So things like culture, things like language, if poverty, which is a socioeconomic condition, with poverty, there's research that shows, that the high levels of stress come along with, being in poverty, and then that impacts your physical health. And then when we talk about culture and the social norms and attitude, I want to speak to things like discrimination, racism, medical bias, sexism, heteronormativity, which can impact, access to healthcare, and not just the access, but then the quality of service that you receive. And then access to technology and communication. So the lists can go on when it comes to the social determinants of health. But again, these are just things that, non-medical factors that influence your health and its outcomes.
Seeing your interests, and this, I did not realize that you were into public health from back in the day, back at, B.C.C, which is where I think I would have first met you.
Yeah. Briefly.
You were wrong, yeah.
Yeah, we were wrong.
Yeah. I had no clue you were interested from then. So looking back now, and then noticing that you would have started your blog, which feels like decades ago.
It does.
And remember, I would have been, for those of you who don't know, Jasmine, pelvic health physio from the episode before, I would have been referring patients to you, to your blog.
My blog, yes.
Yeah, to understand that, I'm not alone. There's somebody else going through this. What I'm experiencing is not in my head. And, I reached out to you. Little did I know that would have sent me down the spiraling rabbit.
Yeah, thank you for joining us.
And then you were like, yeah, hey, look, I have this idea, me and Dawn. I didn't know Dawn, so I met Dawn through you. Who was subsequently come into my life and saved me.
Thanks, Dawn.
Yeah, saved my messiness. But that is how I would have been introduced to the concept of BAEP.
Yes.
So tell us a little bit about why you would have reached out to others. What caused you to decide, in conjunction with Dawn, to start this?
From as long as I remember, I've always been a part of coalitions of sorts from church. I was part of our health guild in my church, my home church, in my community. And then at one point, I was also a member of the youth advocacy movement, the youth arm of the Barbados Family Planning Association. And so there was always this notion, kind of, I guess, naturally embedded in me, that collaboration is the way ahead and a collaborative effort is a more sustainable one. I mean, obviously we have there are always going to be issues with different people and different mindsets. But, you know, once there's a clear goal and everyone is willing to work towards that goal, I thought that would be a lot more sustainable. And I don't know if you remember, but at our official launch, in my address, I made mention of this African proverb, and it goes, if you want to go fast, go alone. If you want to go far, go together. And I knew BAEP needed to go far, because again, we were just starting out. These are conditions that were prevalent, but they were not spoken about in wider society. And so we needed to be sustainable. And so with that being said, I also knew that I have my deficiencies. I have my strengths, but I have my deficiencies, and I'm really quick in identifying, you know, those and then the strengths in others. And I have no problem giving the floor to persons who are more experienced and knowledgeable than I am. And so, as we said, with Dawn was the foundation of endometriosis advocacy in Barbados. So I just want people to know, like, Dawn started her social media advocacy, I believe, in 2009 or 2010. So she just did it by herself. She was very proactive, and so I always give
attract people from all over the world.
Yes, so I always give her props for that. This is Dawn's, you know, Dawn really started it for us. But so I knew that because I wanted to formalize the actions moving forward, she needed to be at the forefront. And she's wonderful, guys. And then she also has this acumen administratively, and then her accounting skills are yes, they're so, and so those skills have really been pivotal in how we manage to be as successful as we are, because I think we're successful, and continue to be, especially with the limited financial resources we have, because we, as we know, we are all doing this as volunteers, and we all have our, you know, our full-time jobs outside of this. And so it takes a lot of effort. We get donations, we get sponsored, but we don't have like a steady source of income. But we have not let that, you know, been a huge barrier for us. And I credit a lot of that to Dawn and the way in which she's able to help us manage those limited financial resources we have. And then just generally having persons with lived experiences to inform the activities and initiatives. And this goes back to the public health approach that I spoke to. It makes no sense creating programs and initiatives and rolling out, you know, materials, and it doesn't fit the context. It doesn't speak to the individual. And so that's why having other persons with these lived experience coming. And I'm a strong believer in two things. Nothing about us without us. So that's why, you know, the majority of our board and our officers are persons with these conditions. And then also, I'd feel really disingenuous if I started to go and speak for persons with P.C.O.S. and share their stories solely. I mean, sometimes I do have to educate people about P.C.O.S., but I always preface it to say, I don't have P.C.O.S. I am just giving you the research. I am giving you these risk factors. I don't have a lived experience with it. And a lot of times I try to find persons within our community that have these lived experiences to go share their stories, because that resonates a lot more and there's value in that. And I believe everyone needs to have, if they're willing to, again, it's a personal choice, but if they want to have a platform and have their voices to be heard, they need to be heard. And again, with that being said, I'm also not the only person with endometriosis from Barbados. All of our experiences are not the same. My experience and Dawn's experience, not the same. We have, I will call her our youth ambassador, Shante. Her experience is not the same. We are not a monolith, and it's important to hear these varied experiences and to be inclusive, to inform the narrative and the way forward.
I always say, you know, so happy to be included in the organization, not just because of my background professionally, but I always say I do not have endo or P.C.O.S, but that doesn't mean that I can't be invested and I can't be, you know, passionate about it and be an advocate for it. And I always like to highlight this because it shows that anybody can be an advocate, anybody can speak up about these conditions, educate around these conditions. And, you know, I always say, again, whenever I go on our behalf and I give talks, I always say, everybody knows somebody. I am convinced everybody knows somebody who has endo or PCOS. Mm-hmm. And I always say, if you think, well, I don't know anybody, it's just because they haven't told you, right? We all have aunties, mummies, sisters, friends, colleagues, team members. You know, I mean, you look at how common these conditions are, and you know how small Barbados is. You must. So this really is everybody's business. Mm-hmm. Everybody's, you know, role to speak up and, you know, advocate. All right, so moving on now to one of my favorite topics, women's health. Tell us your take and your perspective on women's health.
Okay. So I will start by saying you have sex and gender, and both of these have impact on your health because, you know, the biological and then gender-related differences. For this conversation, for that particular question, I want to speak specifically to the health of cis women and girls, as just because I don't feel as though I'm equipped or educated enough to, you know, be as comprehensive to and really, again, I don't have the lived experience to speak to those experiences, to those who identify otherwise. But their experiences are valid and need to be highlighted. And so if, you know, there are persons out there that identify as trans or non-gender conforming or anything along the spectrum, but, you know, want to speak to these issues, give us a holler. But simply put, women's health is a concept that falls under population health and refers to the health of women and differs to that of men. And with both women's and men's health, they've been defined in a lot of varied ways. But if we speak to health broadly, the World Health Organization defines health as a state of complete physical, mental, and social well-being, not merely the absence of disease or infirmity, because I think a lot of people think health is just the absence of disease or the absence of illness, and that's not the case. And then on that definition, you would then tack on in women. And with women's health is then further subdivided, and it generally includes things like maternal, newborn, adolescent, and child health, gender and reproductive rights, and reproductive health and research. And so I'm gonna get on my soapbox now. Truthfully, there is a really heavy focus on reproduction in women's health, and it's needed. It's understandably necessary. But in my opinion, it's been problematic because, yes, it helps to make sure that there are resources available for a woman during pregnancy and childbirth and, you know, children, you know, newborns and all of that. But then it also inadvertently, I'm assuming, perpetuates a societal belief that only sees women as agents of reproduction rather than complex beings. And when I started my personal advocacy, and then when we got together to, you know, formalize BAEP, that was something that bothered me a lot, because it seemed as though a lot of the times for women, our value and our worth is hinged on reproduction. You know, when you're gonna have so it starts off when you're younger, you know. You know, you do everything to scare us into not having, you know, sexual intercourse, and then you hit a point and it's like, where are the children? It's like, so don't have sex to have children, then have sex and you have to have children.
Right. And if you're having sex, where do you have? Like, I had a patient to Friday. She was like, "Do you live by yourself?" I was like, "No, I have a husband." She goes, "So why you don't have children?" I was like, "Okay."
And you see, that's why within our advocacy, we constantly reiterate the message: don't ask people about their reproductive health. And a woman's reproductive health is not the only aspect of our health. And yes, we are advocating for menstrual pelvic health disorders, but it's not just in the context of reproductive health. It's not just in the context of fertility and infertility. We're trying to, you know, ensure that people know that we are We are whole beings, whole complex beings. And so, you know, when I was growing up, the pain that I experienced from my periods was impacting the quality of life overall. It was impacting, you know, how I was able to focus in school. Then it impacts, you know, your economic well-being, as you so rightly mentioned. You know, if you miss too many days of work because of a period, a painful period, I should reiterate, a debilitating painful period, you know, that could be problematic, and then you might have to take less hours, or you could be fired. And so that has absolutely nothing to do with your reproductive capability in and of itself. And so I think people need to recognize that, yes, these things are really housed under sexual and reproductive health, but they impact every single point in our spectrum as human beings. And so that's why we really want to advocate more. So yes, we are advocating for access to healthcare and healthcare services. We are advocating and teaching people about, you know, assisted reproductive technology and fertility versus infertility. And we have, you know, wonderful, you know, relationships with our partners on island. But whether or not you reproduce as a woman does not negate your worth.
Exactly.
Like,
say it again for the people in the back.
Your childbearing capability is not indicative of your worth as a woman. And I think that's something that BAEP strives to really get out there. And conversely, you wanting to have a child, you wanting to naturally conceive, or, you know, use assisted reproductive technology or whatnot, and you're seeking out help in doing so because, you know, because of these conditions, they might be some difficulty, that also doesn't negate your worth. We need to understand that the fallacy of, you know, this is the way it's going to go for every single person, where you just get pregnant, it really isn't. There's so many different factors that come into play. And then along with getting pregnant, you know, you still have to deal with things that can impact the pregnancy, impact, you know, the that pregnancy coming to term, and then the subsequent, you know, maternal health after that. And so we need to kind of expand our thinking about women's health past just reproductive health. And then that, because of that narrow-minded thinking, there's also, you know, that issue with discrimination against women and girls, and the things that they will encounter that are attributed to the socialization of the predominant culture, and that presents those barriers and resources to access to education and healthcare. And so I think that's why we need to speak to women's health, but we need to speak to women's health on a broader level outside of, and still including reproductive health. So I'm off my soapbox for a little bit.
I also want you to hit home how important it is for there to be research in the Caribbean and in Barbados, considering that whenever I give these talks, I have to use, all of us, when we give these talks at workplaces, churches, etc., we have to use evidence from Australia, Canada, America, showing that, you know, we just spoke about physical and social determinants or impacts on health, and why it's so important for us to have specific research.
When it comes to the ongoing research, I think that it's important that the outcomes are really outcomes, and then the subsequent interventions that are going to be designed need to be applicable to the population in the population context, which is why it's important, I think, for us to still keep lobbying for, we've started doing it, but to keep lobbying for more research in this area within the Caribbean context. Because yes, you're right, we do use a lot of international figures that are readily available on these conditions when we do our community advocacy and outreach. And whilst that's great, and it's great that there's research, the populations that the research has been done on might not necessarily be representative of, the Caribbean population. And with that being said, comes the concept of health equity versus health equality. So I will use the analogy, I've seen it done two ways. There's a fence with these three individuals behind a fence, and then there's an apple tree with individuals trying to reach the apple. I think I'll use the fence because it's easier to explain, I think. With the fence, you have a tall person who can see over the fence, like clearly. No, the fence doesn't really bother them. Then you have a person, a medium-sized person for this context, that can just see over it. So they're like, if they like did a little dip, the fence would be in their, would impede their sight, but more or less they could see over it. And then there's the shorter person who can't see anything because the fence is completely blocking their view of, I think they're watching a game or something. And then these boxes are brought in. The boxes are the same height and width, and everyone is given these boxes to stand on, right? And so if everyone is given the same box to stand on, then the same degree of barrier is still there. So yeah, maybe the short person can still barely see over the fence, but it's still not really allowing them to get the same vantage point as the taller person. The taller person just got taller, so now they're seeing even more. So that is equality, basically, where you're giving everyone the same resources in the same way, at the same time, in the same context, not taking into consideration those social determinants of health we spoke about earlier. And that's where equity comes in. So equity considers, and this is where we talk about, I will bring in intersectionality here. All the isms, I call them the isms, I'm sure other people call them the isms. I did not coin the term. Sure, I saw it somewhere, where you have racism, sexism, ableism, things like religion, because we know that there's religious privilege where Christianity in a lot of places is the more predominant religion. You have heterosexual privilege. You have, I'm sure, Kimberly Crenshaw, I'm trying to do justice. But all these isms, all these things play a role in who you are as a person, and then how people perceive you, and then how the resources are distributed to you and disseminated to you. And so it's really important that a person's culture, context, life experiences, and all of these different characteristics of a person are considered, so that, and I'm speaking specifically from the access to healthcare perspective. And I'm sure it can be applied to other perspectives, but that's not where my expertise lies. So then you give the shorter person enough boxes so that their vantage point is on par with the taller person, and then the person in the middle also gets the relevant number of boxes for their context. So know that everyone is at the same level, because the resources are disseminated in an equitable way as opposed to just an equal way. So these are the things that we have to consider in public health.
Now we're moving not too far away from the topic before, but let's talk a little bit about menstrual hygiene. And I guess then you could segue into menstrual disorders, which we would have been chatting about before.
Right.
Yeah, and tell me, how important are these? And when do you think we should start educating children? And I'm going to say children, I'm not going to say girls, because you know how I feel with this.
I know, I feel the same way.
Yeah. So when do you think we should start educating children on these?
I agree with that. I think we should start educating persons, people, individuals.
Yeah.
As early, so the World Health Organization kind of defined adolescence as a period that corresponds to this whole set of development that is happening within an individual, and it occurs between, you know, 10 and 19. So 10, I would say personally for me, 10, I believe that the formal education about sexual and reproductive health and rights, including menstrual health and hygiene, should really be initiated at 10. That might be contentious for some people. And I know that in a lot of places, this does occur in some abridged form. So, you're leaving, I'm using our context, you're leaving primary school, common entrance or whatnot. And some schools, some teachers may, start to teach you prior to going into secondary school about your period, and might just leave it there. Or they might teach you about your period as well as, sexual intercourse. But I think it is lacking in some instances from my experience, and I will list some reasons why. I think a lot of it is fear-based teaching and not comprehensive and inclusive and more informative rather than fear-based, because it really just a lot of people just learn about the risk of pregnancy and contracting STIs. And we know that especially in conservative cultures, that might be the case. And there's a lot of fear associated with it, and then that leads to my second point, where you have stigma as it pertains to then teaching about menstruation and periods, and the use of euphemisms. Like, I love a good euphemism, don't get me wrong, but then using euphemisms for your genitalia and sexual intercourse and other activities really it acts as a barrier to effective learning, I think. I don't know why it's still a thing. We don't have an issue saying, I have a nose, I have an arm, I have a leg, and these are all parts of the body. But if I say vagina, penis, areola, anus in certain settings, you can see people get visibly uncomfortable. If I say period in certain settings, people get visibly uncomfortable, even though these are body parts for the ones I said previously. And then this is something that naturally happens to, cis girls and women. And it still boggles my mind. And I understand for some, the culture is a culture of, it just might be cultural. I'll just leave it there. But a lot of the times it's not cultural, because we talk about sex and sexual activities a lot in the Caribbean. It's in our music. So how on the one hand you're talking about, all of these sexually suggestive acts in music, in media, but then when it comes to adequately educating our population, it's all hush, you shouldn't talk about it.
Even our young people, they're listening to, this music, but then when it comes to learning about it, all of a sudden everybody's uncomfortable.
Yeah, so I think there's a sense of cognitive dissonance, a community sense of cognitive dissonance that we need to really evaluate if it's in our media, and if it really is part of our culture, where we're sexual beings, we talk about these things in fun, flagrant, creative ways. Then the education, the actual comprehensive education, needs to be behind it. And I think that's where there's a gap. And then, so we need to do that to basically change the narrative and break the cycle that is associated with reproductive organs and the shame associated with having a period and, menstruating. And then it also leads to my third point, again, my opinion. It significant gaps of information about mutual respect for partners, consent, and bodily autonomy, especially for girls and women. These things are not widely, the information about these are not widely provided or discussed. And I believe it's critical to do so at a very, very early age. And then since 1994, the International Conference on Population and Development, that happened in 1994. Governments actually agreed that the information and services about sexual and reproductive health and everything that is associated with it, like pregnancy and STIs, and then infertility. And with infertility, we have to talk about these conditions that are associated with infertility. They agreed that this information should be made available. And yet, this is the position we found ourselves in, where we don't really get this information. And so that is why I think it's important to learn about not just menstrual health and hygiene and the associated disorders, but learn about them in the context of, yes, sexual and reproductive health, but also, as I said before, they don't only stay within that sector of health. They don't only stay within that sector of life. You get this diagnosis, and then it can impact you financially, it can impact you socially, and it can impact you in your, intimate relationships. It can impact you mentally and psychologically and emotion. It just extends so far into your life outside of your reproductive health. It's critical for us to have that information and then develop skills, individual skills, and then also have those resources developed out that are more comprehensive in addressing these aspects of health and well-being that are needed in our society.
If we think of, let's go back to secondary school or primary school.
Yeah.
I remember when we're outside of my parents, right? Where I first learned about menstrual health. Now, obviously, when I did learn about menstrual health, they weren't talking about things that can, like this is what happens, but you can have pain. You talk about pain, but you don't talk about they don't get into the disorders.
Right.
And obviously, I think we were separated. So it was the girls, and then the boys were doing something else. And I feel like if we can kind of target maybe guidance counselors. I mean, I don't know. Again, I'm not the person who would determine who should be given all this information, but I think in generally, adults need to be more candid about the way they speak about these things. And if you are candid and if you show that you're not, because I speak about uncomfortable things with patients all the time, but if you can show that, it's not a big deal for me, your audience won't think it's a big deal.
Right.
And it probably needs to maybe start there. And I think men and women, because, my dad is one of the persons who taught me how to wait from the front to the back. Right? That can enforce, some of my concepts of vaginal health. So I think it's important for women and men to be educated. But I think it starts, I don't know, it's a weird cycle. I guess it starts with adults educating children, and then these children going into adults that will continue to educate. But also this whole thing of periods being taboo and being way in 2020 should we be hiding a pad, and you have to stress about, okay, how am I going to get to the bathroom? This pad concealed. Where are we still doing that in 2020? Why is it that it's so uncomfortable to show, when the ads on TV, the water that they're using is blue.
It's blue.
Things like this. There's so much around this topic and so much big deal around, talk about, there's a word that they use, even the word feminine hygiene insinuates that, it's something that's dirty. You get what I'm saying? It's just...
Yeah. Language is important. I keep saying that in my job. Language is really important.
Yeah. So, before we see the really rabbit hole. Thank you so much for, everything you said so far. It's been really insightful. But is there anything else that you want to add in, or anything else you want to hit home? Anything?
Yes, I do. And it's going to be a tack on to what you just said, because that was really why we developed out, the BAEP developed out that book, Invisible and Not Imaginary. Pardon?
And our school
program, because we wanted to have the candid conversations about menstruation, menstrual health and hygiene, vaginal health and hygiene, and then, talk about these conditions that it's not included in the curriculum as far as I know at this point in time, so that not just women and girls, but men and boys are also aware of it. Like, and I will refer to one of our stories in the book where, it's a single dad with a young daughter who is now having her first period. To really, again, hit home that point, a male figure is also supporting the female figure in his life, as she's navigating this whole concept of menstruation and menstrual health. So I think it's critical that persons keep engaging with us and help us inform our strategies. I think that's what we are really, that's how we would really grow and develop. I would like to kind of list our 7, sorry, my dog again, our 7 points, but right now I'm drawing a blank for all of them, but the last one is be kind always, and I think I will leave it there. Be kind always. You don't know what people are going through. You don't know the context a person has come from. You don't know the context a person is in. So a lot of understanding and empathy goes a really long way, especially in these really unprecedented times that we're in. Yes, you have your own personal things going on, but so do other people. So I think just recognizing that your perspective is not everyone else's perspective and your experience is not everyone else's experience, and just being a form of support for other people will go a long way. And I'll end there.
Yeah, that was perfect. That was a perfect ending. Yeah. Thank you so much, Julia. I feel like we talked about public health. Mm-hmm. We had, that spoken word bit on we covered a lot. I'm sure it'll be very useful. Mm-hmm. Please, yeah, it was, and please be engaging in the comments. Let us know your thoughts. Mm-hmm. what you thought pelvic health, not pelvic health, public health was.
Public health again.
And go back and watch. Tell us, how this maybe change your perspective on public health. Yeah. Give us a little bit of your ideas, maybe on how you think we can change, the talk around menstruation and, where do you think it should be included in the education system, etc.
And thank you for being such a wonderful host, Jasmine. I think you might have another dog coming up.
Thanks a lot. Anytime you need me, just let me know. Also, remember, we have a giveaway going. Mm-hmm. So I think, so go on our page and on P.C.O.S and look for our giveaway. We're giving away a really good book.
Yes, so thank you for that, Jasmine.
A chance to win.
Yes.
All the best, Julia, and we'll see you again soon.
Thanks, Jasmine.
Bye. Bye. Everybody, thanks for watching.
Thank you.